This explainer is based on Anxiety-Related Dizziness, a Vestibular Physician Deep review of panic disorder, generalized anxiety, and hyperventilation syndrome, published by Australian Dizziness Clinics.
Welcome back to part 2 of our explainer series. I'm really pumped to dive into this one today because anxiety-related dizziness, well, we literally see it all the time in clinic. And here's the thing, it has a very real, tangible anatomical substrate that we're going to unpack. It's not just all in the patient's head in a purely psychological sense. Actually, it is deeply hardwired right into their neuroanatomy.
So here's our roadmap for today. We'll look at the vestibular-anxiety interface, trace the actual neural circuit, explore the bidirectional amplification loop, then zoom out to 3 clinical explanatory models, and finally, translate all that anatomy into actionable treatment. All right, let's just jump right into section 1, the vestibular-anxiety interface. We're bridging the gap between structural and psychiatric symptoms here. Now, for everyone tuning in, this is a foundational concept. The vestibular and anxiety-related neural circuits share extensive structural connections in the brainstem and limbic system, and I really want to emphasize the word structural here. It's not just a coincidence, and it's not simply a byproduct of someone, feeling nervous about falling over. These pathways physically intertwine. Understanding this interface is an absolute game changer for how you manage these complex presentations. Moving right along to section 2, tracing the neural circuit. We're going to follow that afferent signal right from the labyrinth straight into the fear network. Let's trace this signal's journey step by step. It originates way down in the peripheral vestibular organs of the labyrinth, travels up to the brainstem vestibular nuclei, hits the parabrachial nucleus, and then fans right out extensively into the amygdala and the broader limbic system. Okay, let's pause here because the parabrachial nucleus, or PBN, is really the star of the show. Sitting right there in the dorsolateral pons, it basically acts as the primary switchboard. It bridges physical vestibular perturbations directly with precognitive fear appraisal. So what does that mean for us? It means that before your patient even consciously processes that they're feeling dizzy, their brain has already smashed the alarm button and triggered a fear response. From that PBN switchboard, the circuit just explodes outward. It projects directly to the amygdala to handle fear and vigilance, triggers the locus coeruleus to drive norepinephrine arousal, and drops down to the hypothalamus to kick off the HPA-axis and pump out cortisol. This right here, this is the exact physical hardware of a panic response, and it's getting a direct, live feed from the vestibular system. Now, let's shift to section 3, the bidirectional amplification loop. This is where we see that it's absolutely a two-way street. Think about this like a continuous cycle. Notice the reciprocal arrows on the far left, creating a bidirectional feedback loop. So while a vestibular signal can trigger fear and arousal, that newly elevated anxiety state projects right back down and directly turns up the dial on the vestibular nuclei. The systems just continuously feed into and amplify one another. Let's get into the nuts and bolts of that loop. Elevated norepinephrine from the locus coeruleus actually raises the VOR, the vestibulo-ocular reflex, gain. Meanwhile, elevated cortisol impairs the brain's ability to undergo vestibular habituation. Throw in some direct feedback from the amygdala altering vestibular firing rates, and boom, you end up with a genuinely, measurably sensitized vestibular system. The patient isn't just imagining things, their neurochemistry is physically making them hypersensitive to motion. All right, section 4. 3 clinical explanatory models. We've looked at the hardware, so let's translate this anatomy into clinical software to explain exactly how this malfunctions in the patients sitting across from you. Let's contrast the first 2 models side by side. In the psychosomatic model, the anxiety disorder is the boss. It's the primary driver causing autonomic arousal and hyperventilation, which then creates secondary dizziness. On the flip side, we have the somatopsychic model. This is where a primary, very real, physical vestibular event, like an acute bout of vestibular neuritis, plants a seed for a secondary fear and avoidance response. And that response sticks around, way after the original structural issue has resolved. These complementary models essentially operate as parallel pathways. And the kicker is, they all converge on the exact same endpoint: conscious dizziness and spatial disorientation. Whether the origin story is primary anxiety, primary vestibular dysfunction, or a sensitized network, the clinical presentations heavily overlap. Identifying which of these pathways is dominant, that is absolutely crucial for guiding your therapy. Now let's zone in on that third model, network alarm theory. This is fascinating. It beautifully explains how a sensitized loop causes a predisposed patient to generate a conditioned panic response to perfectly normal movement. Because that circuit, the amygdala, the PBN, the locus coeruleus, is so abnormally wound up, the brain misinterprets totally standard, everyday vestibular signals as a massive bodily threat. It's basically a false alarm triggering a very real autonomic storm.
Which brings us to Section 5, Translating Anatomy to Treatment. Let's look at why understanding this hard neuroanatomy completely changes your approach and the incredible clinical power of validation. Figuring out the dominant pathway dictates your next move, right? Whether you start with vestibular rehab, CBT, or medication. But regardless of the pathway, here is the major takeaway. Simply validating this biological mechanism to your patient is profoundly therapeutic. It is not a concession. Telling them, hey, your elevated norepinephrine is physically altering your VOR gain, and your dizziness is an anatomically real response to a sensitized loop. Having that conversation removes the stigma, builds immediate trust, and honestly sets the entire foundation for effective rehabilitation.
Before we wrap up, I want you to ask yourself, how many patients in your clinic right now are trapped in this exact bidirectional loop, just waiting for someone to finally explain their symptoms? Join me in Audio 3, Clinical Phenotypes and Hyperventilation, where we meet panic disorder, generalized anxiety, and the hyperventilating patient. For additional resources, including the full literature review, clinical cheat sheet, and patient leaflet, visit AustralianDizzinessClinics.com. Please subscribe to support the channel.